So a mass casualty incident is classified as any accident or situation that results in more patients than the daily planned resources can handle. Every hospital is equipped to handle X amount of patients per day, and it's generally based on the number of hospital beds that are at that facility. For instance, at Willis-Knighton-Bossier, I think that facility is now about 130 beds, give or take. And so that means that on any given day, we know that we can handle roughly around 130 patients. Well, a mass casualty incident is something where there's an influx of so many patients that the daily resources aren't available to handle it. So what happens is that local facility begins to depend on other agencies in the area. You initially will branch out to local agencies, and they will help sustain the facility for a few days, up to 5 days, and then the local departments roll over to the state level, and they start to seek out help from the state and or federal agencies. Okay, so it's kind of a process. Initially, the local area will handle it, the local facility, the local city government, and then eventually it becomes a state issue and or a federal, and that's when they would declare something in cases of federal disaster. That's kind of how that progresses. So our classification, mass casualty classifications, are based on the anticipated level of response that's going to be needed, if it's going to be local, state, or federal. A level 1 is kind of a local emergency response type thing, where the city itself or the community itself can handle it. A level 2 becomes a regional issue, where other areas or agencies within a certain mile radius, surrounding communities or cities might help. And then a level 3 emergency or a level 3 incident involves the state or federal assistance. Okay, so depending on what's going on, the local government might make a decision to ask for state or federal aid, and that's kind of how they classify mass casualties. Having a disaster plan is an essential part of a mass casualty situation. Even though they don't happen very often, you've got to be prepared. So we have community-wide disaster plans. There are also state and federal level disaster plans. Okay, everybody's got to have a preparation, got to have a plan in place. An integral part of the plan is to have an incident command system. It's a federally mandated command structure. Basically, that just means that a few years ago the federal government came in and said, okay, we have to get better at handling mass casualties. And so they kind of laid out some guidelines for how to have an incident command center to run and organize all of the goings-on. So part of that for the hospital system is to have a hospital incident command system. It's a modified system that is specific to the hospital and for law enforcement agencies, so that we can work together in these crisis times. All right, the EOP, or Emergency Operation Plan, is the plan that a healthcare facility has in place It's required by Joint Commission to have one. So every hospital system has to create a plan, and then we have to practice it at least twice a year. So I don't know if y'all are aware of this or not, but every hospital system has to actually practice a mass casualty scenario twice a year, and we actually do this at Bossier. They typically will incorporate high schools and or colleges. Very often we get the drama department from BIPSI, as well as the drama departments from some of the local high schools, and then they'll get high school and college students to volunteer. And every year it's a little different. Usually there's a big one and a smaller one. It's usually how we do it here in Bossier Parish. The big one involves fire department, EMS, local law enforcement, state law enforcement, and then the hospital. And so a lot of times they'll plan, like they'll stage a plane crash. You know, they'll do a mock plane crash or a mock train accident or a mock multi-vehicle pileup or something like that. And they have the students be victims. It's really kind of cool, actually, because they let the art department, the drama department, they let them create wounds and costumes, and you know, they do a really great job. But they stage this incident, and we get to practice our emergency operation plan. The plan itself focuses on the most likely types of disasters. So, you know, whatever the local risk is in whatever area that hospital is, that's kind of how they drill their EOP. Here we do tornadoes, plane crashes, which I know plane crashes are not very common, but everybody kind of has to be prepared for that if you have a major airport. Again, train accidents, auto accidents, chemical plant explosions, you know, things like that, fire on base, you know, just all kinds of things that are specific to our local area. So this emergency operation plan has some very specific components that have to be included in it, and it again is required by the Joint Commission. So there has to be a plan or a mechanism to activate the response system, how you're going to do it, when to initiate it, you know, when is it time to say, all right, it's time to go. They've got to have a command structure or communication structure in place internally and externally, meaning within the hospital system, and to communicate to facilities outside the hospital, such as law enforcement, fire department, how to coordinate the care. There has to be a plan in place that says where we're going to put what patients, how we coordinate patient care coming into the facility and patients that are going out of the facility, because there's going to be a constant influx of patients being admitted, and then there might be patients that have to be transferred somewhere else to a different level of care. So we have to coordinate very rapidly how we're getting them in and out of the facility. Security is essential inside the facility and also in the surrounding community, in the area around the hospital. There has to be identified resources as part of the plan so that when we put it into place, we have all the agencies and the phone numbers and the contact people that we need, state, local, federal. How do you get in touch with them? How do you access them? Because in the middle of a crisis is not the time to go be pulling out the phone book looking up a number. So all of that has to be readily available. There also has to be a plan for management of personnel, traffic flow, visitors, the media, who talks to the media, what do you say to the media, what personnel go where, what is my job as a nurse, where do I report to, and what do I do. So there has to be a very specific plan in place to tell everybody what to do for people management. Also has to have a plan for data management, charts. We're going to computer charting almost everywhere, so you have to have a plan in place to handle that many patients, and then a backup plan if the computers go down. The demobilization plan has to be thought out ahead of time. Who's responsible for saying, all right, this crisis is over, we're going back to normal? So who makes that decision, and what's the criteria for making that decision? The after action response is the debriefing stage where, after everything is taken care of, everybody gets together and says, all right, what worked? What didn't work? What do we need to change? This needs to be developed, or we didn't think about this. So that's the critique and the debriefing. Part of the EOP, they have to have in that plan how they're going to practice, who all is going to be involved in the drills, the community agencies that are going to be involved in those drills, what resources might be needed for an extended period of time, food, water, medicine. What do you do when you run out of medicine in the facility? You've got such an influx of people into the hospital that you run out of gauze, or you run out of a certain medicine. So what's our plan to get more medicine into the facility? Incident planning, meaning how are we going to handle massive fatalities? Is there a morgue at that hospital? Are we ready? Are we prepared? Do we have a place to put multiple fatalities? Places like Willis-Knighton-Bossier, for instance, there's no morgue at Willis-Knighton-Bossier. So how would, what is Bossier's plan for handling multiple fatalities? And then the last part of all this is education for hospital staff, all of the agencies that are going to be involved. There has to be an education plan in place that talks about how training is going to occur. So, and then, like I said, once we get this EOP in place, then twice a year we have to actually implement it. So that's part of the training process to make sure that all hospital staff and all of the community agencies are prepared in case something does happen. Initiation of the plan itself, once we set the plan in place, the first step is identifying patients, triage. So this is where we identify and document patient information. Typically this is done through a tagging system. They'll have what's called disaster tags, and they're color coded. And each color is representative of a severity of the patient's condition. I talked earlier about triage initially at the beginning of the lecture. Well, triage in mass casualty is a little different. It is based on this tagging system. The patients are sorted according to acuity or severity, and the most critical people, of course, get seen first. But the most critical patients, if they are tagged as very, very acutely ill with a poor outcome, it's not likely they're going to survive. Then a lot of times in mass casualty situations, supplies are not used on them. Supplies will be routed to the people who have the greatest chance of survival. So, you know, like I said, triage is a little different with mass casualty. Communicating, we talked about communication with the media and families. There's got to be a plan in place of how you're going to get in touch with families. There has to be a very clear-cut plan for how the families are going to be notified. You know, especially with mass casualties, you've got to get in touch with next of kin for decision making, and you've got to have this plan in place so that it's real clear about how to go about doing it. The nurse's role in a mass casualty situation really depends on what's needed, okay? Now that doesn't mean that we do what's, you know, we're not functioning as a physician, okay? But our role is expanded. It might be outside the hospital setting, okay? It might be outside your normal role of an RN. You know, you might be a med-surg nurse, and they might ask you to go help out in surgery. Or you might be a GI lab nurse, and they send you to ICU. You know, it might be outside of your normal role, but, you know, it's whatever the need is at the time, okay? And that can lead to some ethical conflict. It can lead to emotional conflict because you're not sure about, you know, the area maybe that you're in. You might also be faced with issues of, you know, with resources, if there are limited resources, and they're saving those resources for the ones who are most likely to survive. That can lead to ethical conflict between, you know, not treating somebody. You know, it can lead to post-traumatic stress, which eventually, if it's not dealt with, you know, that can lead to problems with anxiety and fear in nurses, fatigue, and even long-term psychological issues. Okay, so the key here to dealing with this is the critical incident stress management. That's the debriefing. Okay, diffusing, debriefing, you know, working through the situation, what went well, what did not go well, and helping nurses decompress. Okay, the key to critical incident stress management is education. You've got to train staff. You've got to train people involved beforehand. If they know what to expect and they practice it enough, if it were ever to happen in real life, then people just fall right in line and they do exactly what they're supposed to do. And then you can debrief after, but they feel more prepared. Okay, education is the key to helping them feel trained and ready. And then the debriefing, diffusing afterward, helps them with coping. So it's all very important part of this process. The short and long-term psychological effects, you know, managing short and long-term psychological effects, of course, active listening and emotional support. And this could be, guys, I mean, this could be you with a patient. It can be you with a fellow coworker. It could be you with a family member. So it really, you know, you really could be dealing with this in any population. Active listening, therapeutic communication, emotional support. You know, when you're, as far as like families go, provide information that's appropriate but not overwhelming. Initiate or seek out professional resources. You know, media, we at Bossier have a very specific, well, not just Bossier, it's a Willis-Knighton policy. We have a very, very rigid media policy, meaning that there is one person that's designated to talk to the media, and that's it. Nobody else is allowed to talk to the media, and you shouldn't. You know, that's how things get blown out of proportion, and people panic for no reason. If we route everything through one person, then there's a much less chance of miscommunication. Encouraging, you know, to return to normal activities and social roles as much as possible, as quickly as possible, but not in an unrealistic way. You know, some people want to jump back into normal and pretend like nothing ever happened. So you really have to balance that with processing through, and that's where that critical incident stress management comes in. And then anybody that has ongoing signs of PTSD or stress response should really be referred to counseling. And at any time there's a mass casualty situation, there's going to be an influx of counselors, therapists, you know, psychological support people. So they will be readily on hand or available for people who need it. Preparedness and response is based on recognition and awareness of situations. So we have to kind of be prepared at all times. You know, that plan has to be updated. It has to be ready to be implemented. Education and training has to be done, you know, in a timely manner. And then you have, you know, administration, hospital administration has to be aware of potential issues. So that means they've got to stay on top of stuff. Community agencies have to be in contact with state and local authorities and federal agencies and things like the CDC. You know, we in this area have Barksdale, so, you know, the Air Force Base, and so we have to, I guess, consider at least the fact that we are at a little bit greater risk of having a mass casualty situation. Back this summer, when all the flooding took place, there was a busted gas line not half a mile from Willis-Knighton Bossier Hospital. And even though we didn't actually initiate any kind of plan, there was a discussion among administration and supervisors about what they would do if they had to go into action. They also had a plan in place in case the levee broke. The hospital is roughly, I think they said, 1.5 miles from the Red River. And at that point in time, they weren't really sure what the river was going to do. And so, you know, they had a plan in place in case they had to begin evacuating. So just being prepared, anticipating during springtime when the weather's bad. You know, Willis-Knighton Bossier has been hit by a tornado. Well, the building wasn't hit by a tornado, but it hit not far from the hospital. And we were the facility closest to the situation, and so we had an influx of patients. We had a mass casualty situation. So preparation at all times and being aware of what's happening in the community, in the surrounding area, to stay on top of stuff. Having the MSDS sheets readily available in case it's an issue of chemical exposure, and then of course having all the appropriate personal protective equipment on hand and available. Alright, speaking of the personal protective equipment, with mass casualty, that's another component of emergency preparedness, and it's a little bit different or more in depth than just what you're used to. Okay, we talk about standard precautions all the time, but PPE in emergency preparedness is a little more specific. Okay, so the purpose is to protect us from any hazards that we might face while we are taking care of a contaminated patient. They can be chemical, biological, can be radiation based. So our levels or categories of protection are based on those types of contaminants. We have level A, level B, level C, and level D. Okay. Level A is basically the highest level of protection. So you would use a level A PPE when the highest level of protection is needed. Okay, and that's going to be coverage or protection of respiratory, eyes, mucous membranes, skin, everything needs to be protected. So you're using what's called a self-contained breathing apparatus, or at the hospital we call them scuba gear. And we actually have to have one in the surgery department because one of our sterilizers is a gas. It's a gas-based autoclave. And if there were to be a gas leak, then we would have to use the scuba system. So it's a self-contained breathing system, vapor tight, chemical resistant, and it's full head-to-toe garb. The whole headgear, every part of your body's covered. Level B is high level protection, high level of respiratory protection using a scuba bag, but not as much skin and eye protection. Okay, it's still a chemical resistant suit. It's highest level respiratory, but a little bit less in terms of skin and eyes. The level C is just an air purified respirator, coveralls with a splash hood, chemical resistant gloves and boots, but not the self-contained system. And then level D is going to be just typical, what you would typically utilize at work every day. So level C and level D are the most often types of PPE that are used in the hospital under normal circumstances. But as far as mass casualty goes or emergency preparedness, we have to have training on these things, on how to use them properly, how to don your personal protective equipment, how to remove it without exposing yourself or contaminating others. Last spring when the Ebola stuff got, real kind of keyed up in the United States, the hospital, several of the nursing staff had to go through Ebola training on how to put on the correct PPE and how to take it off without exposing themselves. So training has to go into all of this. People in surgery that might be using the level A or the level B self-contained system, they have to be trained. They have to be in-serviced once a year on proper use of that system. Decontamination is another essential component. Hospitals have to have a decontamination plan. Must be at least a two-step decontamination plan where you remove exposed or soiled clothing and then rinse thoroughly. That's part of that process. So you have to get rid of the contaminated clothing or equipment or whatever's been exposed, and then thorough rinse. So decontamination is the process of removing those contaminants and trying to render them harmless. Education, training of all staff, removal of clothing, jewelry, rinsing with water immediately, and then a secondary wash with soap and water and a thorough rinse. These are things like eye wash stations. You know, there's an eye wash station in every nursing unit in case you get splashed in the eye with something. But there's also a decontamination plan in case you are exposed in some way. And then there also has to be a mechanism or a plan in place if the exposure takes place outside of the hospital. Then the pre-hospital emergency responders, they have a decontamination process. So even if the decontamination is done outside of the facility, once they come into the hospital, we're going to do it again. So there's got to be a policy for that too. Some of the potential agents that we could be dealing with or looking at in terms of exposure, or maybe having to do decontamination or just mass casualty in general. Of course, natural disasters, flood, fire, hurricane, tornado. Those are some of the things that we could be dealing with, especially here in the South with our crazy weather. Blast events, that would be something like a bombing or blast lung. The book talks about that, where there's a wave, like a blast wave that travels through a person's lungs and through the lung tissue, causes hemorrhage and tears and hypoxia, can lead to tympanic membrane rupture. Also, blast events can cause abdominal and head injuries. Biological events, biological weapons are often used to spread diseases very quickly among a large group of people. That's going to be things like anthrax, smallpox, Ebola. Biologic agents can be spread in a number of ways, and today we're talking a lot about travel. Different countries and spread of infection. One person can spread infection very quickly and very widely over thousands of miles. So, it's important for us as nurses to be aware of potential issues and the signs and symptoms that come with that. Ebola keeps coming to mind. And then just being aware of how to handle it, isolation practices, standard precautions, and then special transmission-based precautions particular to that disease. And then the disinfection, disposal of waste agents. Ebola there's a very specific plan. There's a specific way that has to be dealt with. So, I hate to admit it, I hate to say it, but that's the way practice is today. We just have to be very cognizant of these type issues. Chemical weapons, chemical substances can cause injury and death very quickly. They also can lead to widespread panic in the community. So, things like nerve agents and pulmonary, things that are disseminated into the air. They vary in volatility, how volatile they are, how toxic they are. Some of them, you have to be exposed over a length of time. So when it's disseminated into the air, the longer you breathe it, the more exposure, the worse the outcome. So, again, we have to be prepared, kind of cognizant. Just know that your facility has a plan in place for all this stuff. Radiation exposure from nuclear weapons. We don't live by a nuclear power plant or anything, but some places do. Some places have that. So we have to be aware of radiation exposure and how to deal with that. Radiation exposure is greatly affected by time, distance, and shielding, meaning how long was the person exposed. The longer they're exposed, the greater amount of radiation they have in them. How close were they to the source, and were they shielded at all? If it's a direct exposure, of course, that's going to be a whole lot worse than if they were shielded somewhat. There's external radiation, where all or part of the body is exposed. This is types of radiation exposure. External, meaning all or part of the body is exposed. Decontamination is not necessary, and it's not a medical emergency. The patient is not radioactive. Another type of radiation exposure is called contamination, where there's exposure to radioactive gases or liquids or solids, and it does require immediate medical attention, medical management to prevent the patient becoming radioactive. And then incorporation means there is actual uptake of radioactive material into the body, and the patient actually does become radioactive. Now, there are times when we do this on purpose, and this is like radiation treatments, or if we implant radioactive pellets or something like that into a patient for cancer treatment. That's actually incorporation. It's a type of radiation exposure, but it's done under controlled methods for medical treatment. So, we still have to be cognizant of how to handle that radiation exposure, because even if we're doing it for a good purpose, the nurses that are around that patient don't want to be inadvertently exposed. So, there are precautions that have to be taken place there. And then, of course, if it was a mass casualty or a emergency preparedness type situation, that would be a little different in terms of our handling of exposure, but it would still be necessary to protect ourselves from radiation exposure. Decontamination, we talked about a little bit. Typically, they try to triage patients outside of the hospital if they have been exposed, especially to radiation. They try to keep it outside of the hospital, and they'll take measures to limit exposure inside the facility, cover the floor, strict isolation precautions, sealing off the air ducts and the vents, double bag our waste products, stuff like that. Staff has to have water-resistant gowns, 2 pairs of gloves, full cap, mask, goggles. Patients, when they're surveyed for radiation, they'll be evaluated and then directed to the decontamination area. Radiation decontamination, like I said, is usually done outside of the emergency department. And then everything that comes in contact with the patient, if they have an exposure, especially, if we think that they are fully exposed, then everything that comes in contact with that patient has to be disposed of properly. It has to be collected and contained and disposed of the same way that we would decontaminate, radiation. The patient will be reevaluated, and they might get re-showered again. They might get showered 2 or 3 times. And then we have to make sure that that shower water, the runoff, doesn't contaminate. So you can see how radiation exposure can be if it's not, if it's something that happens from non-medical purposes, it can be a beast to try to control. So again, the facility where you go to work will have a plan in place for all of this. It's not like we walk around all day long and say, oh, what if I have a chemical exposure today? But you are expected, wherever you go to work, you're expected to at least know how to access the needed information and notify and act accordingly if that time ever comes. All right, so this is the end of this lecture, and congratulations, this is the last lecture. So you made it, and you don't have to listen to me anymore. So congrats.